My name is Erin Sullivan. I'm a lecturer in the Department of Global Health and Social Medicine and an associate professor of healthcare management at the Sawyer School of Business at Suffolk University. Today's session is focused on shaping the future of addiction care, primary care leaders as advocates and innovators. I'd like to introduce our panelists for today to get us started. First, we have Dr. Becky Lee, who is a family and addiction medicine physician and a member of the street team at Boston Healthcare for the Homeless program, which is an interdisciplinary primary care team providing longitudinal care to people who sleep outside year-round and face barriers to accessing conventional medical care. She earned her medical degree from Tufts University School of Medicine and completed her residency at Lawrence Family Medicine Residency with a concentration in addiction medicine. Becky's clinical interests include reproductive health, gender affirming care, trauma informed care, harm reduction, and point of care ultrasound. She spends most of her clinical time working out of her backpack, meeting patients experiencing unsheltered homelessness in Boston. Our next panelist is Dr. Christine Pace, who is a primary care physician at Boston Medical Center and Vice President and Chief of Population Health Services for BMC Health System. A graduate of Harvard Medical School and she's also a graduate of the internal medicine residency at Brigham and Women's Hospital and the Boston University Addiction Medicine Fellowship. She has held a number of leadership roles focused on the design, implementation, and evaluation of programs to improve integration of behavioral health care with primary care, complex care management for high-risk individuals, and population health management for Medicaid recipients. In her current role, she leads population health programs to support individuals and providers across Boston Medical Center healthcare affiliated Medicaid accountable care organizations, and provides strategic oversight for the Grayken Center for Addiction and other system substance use disorder services. She is a primary care and addiction provider at BMC and attends on the Addiction Consult service. And our third panelist is Dr. Ruth Potee. She is a board certified family physician and addiction medicine physician who works across Massachusetts. She attended Wellesley College, Yale University School of Medicine, and did her residency at Boston University, where she remained an assistant professor of family medicine for 8 years. She is currently the medical director for Behavioral Health Network and the Franklin County House of Corrections. She oversees 10 opiate treatment programs, or OTPs, including the first fully licensed jail OTP in the country. She was named Franklin County Doctor of the Year by the Massachusetts Medical Society in 2015 and has won multiple teaching awards from medical students and residents. Welcome to all our panelists. Thank you again for joining us today. I will now ask our first question to our panelists. And the first question is, what drew you to addiction care within primary care? And what keeps you committed to this work? Is there someone who wants to jump in first?
I'll do this one first. I think if you're paying any attention when you're a primary care doctor, there's no way you're not taking care of a huge portion of folks who struggle with substance use, especially alcohol. And you just have to ask the questions. So, a few of us trained in inner city hospitals. Boston City Hospital was founded, I think, in 1873 for the care of alcoholics, specifically like Boston Irish. And when you look at the who died that first year that Boston City was founded, with the exception, I think, of two cases, they were all alcohol related causes of death. And yet we know that alcohol use is the number one preventable cause of death in our country now. And there's no better person to take care of somebody who's really at one of their lowest points of their lives. Things are really blowing up in their personal lives, in their financial lives, in their own personal health. And it's really hard to come to somebody and describe, I think I'm actually struggling. Or sometimes they have no interest in discussing that they're actually struggling. And yet you're the person who knows them the best. You're their family doctor. You take care of their kids. You take care of their partner. You know their partner's pissed at them. And yet your job is to continue to engage with them and provide them the care that they need. So for me, I'm a 27-year family doctor. I'm like the old one on this call. It's the most important work I get to do in family medicine, other than being an abortion provider and a reproductive health specialist. I think actually helping people decide when and where they're going to have kids is a really critical thing that you get to do as a family doctor or a primary care doctor as well.
Thanks, Ruth, for starting us off. Christine or Becky?
I can jump in. The only thing I would add is, well, I had a funny journey to addiction medicine and primary care in that I knew I wanted to do addiction medicine before I knew what sort of formal path of training I wanted in medicine. So I was when I was at I always knew I wanted to do addiction medicine. I grew up with a mom who was a HIV social worker, and it was like her work was kind of like a fabric of our household. We all volunteered every night. I spent tons of time with her there. So, got to know clients of hers who are struggling with substance use disorders in New York in the 80s. And, it was just a big part of my growing up. My mom also had very severe alcohol use disorder. And so, in addition to kind of being influenced by her career path, I was very influenced by the ways that her disease impacted our family. And so I always knew it was something that I wanted to do professionally, and then was just really drawn to primary care. I think for so many of the reasons that Ruth mentioned, um, and in particular, sort of the array of ways that you can support an individual through the primary care lens. Um, and I think for me, one of the coolest things about doing addiction medicine through primary care has been the opportunity to work with patients longitudinally so that, because I have a fairly time-consuming administrative role at BMC, I have a very limited primary care panel. And so many of my patients I've had for 15 years, they're in very long-term recovery, and it's basically like a coffee date when they come in. It's like we've known each other forever. I also have patients though who've really been struggling on and off through those 15 years. And the real joy there is that they know I'm always here no matter what. And, if they're struggling, if they're using, I'm still here, and ready to support them, whatever their goals might be at that moment. And I think that's really a privilege that's unique to primary care and not something that I'd be able to experience if I was doing addiction medicine through another field. So that's really like just a really powerful and sustaining experience.
Thanks.
Um, my path was really started when I was in medical school. I really didn't know what kind of doctor I wanted to be. And early on in medical school, I started shadowing people. I'm at Healthcare for the Homeless in Boston, where I now work, and was really drawn to working with people who were living on the margins. And I really just loved working with this group of patients who were living outside and not accessing our traditional healthcare systems. And through that experience, I started learning more about addiction, getting to know people who were living outside and using drugs and at various points in their journey in their addiction. And so when I was deciding what kind of doctor I wanted to be, I felt like primary care and with a specialty in addiction would give me the broadest set of tools to help that patient population. So that's what brought me to addiction care and primary care. And the thing that keeps me coming back is again the patients. I just love my patients so much. They are amazing and diverse and resilient and so smart and yet so failed by the health systems that all of us work in. And I feel really lucky to be in a position where part of the team I'm on, we get to be the people who build trust with our patients and then help them access those systems in a way that is not threatening or harmful to them.
Thank you all. Our next question, building on what we heard from y'all in our first question, how do you integrate substance use care alongside chronic disease management without overwhelming patients or clinicians?
I can start with that.
Okay.
I have a little bit of an unconventional job. I'm on the street team at Boston Healthcare for the Homeless, which is a 12-person interdisciplinary team. I'm one of two medical doctors, and our mission is really to access the people who are not staying in the homeless shelters. They're not accessing traditional clinics. They're not really able to get through the front door, so to speak. And so we go to them, and a large percentage of the patients that I take care of have active addiction, either with alcohol or fentanyl or K2 or stimulants. And so being in primary care and family medicine with this specialty in addiction, I can go and meet someone where they are, whether it's in an encampment or under a bridge or on the sidewalk. And rather than saying, oh, I'm an addiction medicine doctor. Let's talk about your addiction. I can say, I'm a generalist. How are you doing today? What are your health goals and how can I help? And because I was trained in full spectrum primary care, family medicine, if someone's like, I have this abscess from injecting into my arm, can you cut it open for me? I can do that. And or if they say, I just found I was pregnant and I've using a lot of methamphetamines and I don't feel safe going to the hospital yet. I'm not ready to go see the obstetrician. I can address their pregnancy and whatever infections they have going on and build that relationship without me dictating the terms, but with that person saying, these are the things that I need and I know myself best. And through that approach, I build trust with patients and they get to know me, they feel comfortable with me, and then over weeks or months or even years, when they get to a point where they're like, actually, like I do want to talk about the fentanyl I'm using. I don't want to be doing this anymore. We already have that relationship to build on, and there's nothing more important than relationship, especially when working with people with a history of substance use who are so used to being stigmatized and judged um, and not treated like a human being when they go to the emergency department.
Thanks, Becky. Ruth or Christine, you want to jump in?
I very much agree that starting with the patient's own goals is really essential. And when you're sort of trying to balance, addiction is sort of one of maybe five or six chronic conditions you're trying to support someone on. You really have to figure out like which one is the priority for them at that moment, and then do some like internal prioritization. Like, if we're working on diabetes right now, like maybe my goal hemoglobin A1C is going to be a little lower given this number, or going to be a little higher given the number of challenges that this person is facing. But I also try to be transparent with the patient about what the prioritization that I'm doing to make sure it aligns with what they're thinking and where they want to go. Like I would never want to make a unilateral decision to not approach a certain chronic condition that they're struggling with if that's not something, if they're really motivated to embark on treatment for that. And then I think also to Becky's point about being part of a team, I think leveraging your colleagues for co-management of those conditions is really essential. Um, and I think being transparent with yourself too about, I always try to document with my note, like patient ideally would be on XYZ. We're going to start with X. We talked about this decision. This is what we're going to do for now. So that you can kind of track progress through time.
Yep. Awesome.
Just listening to Becky and Christine, I'm hoping that the students out there who are hearing them speak are thinking to themselves, oh, I want to be that kind of doctor because that is the kind of doctor you want to be. And so much of the training that you all get now is so much more patient oriented than it used to be. For me, I really think of myself as a public health person, and I really am trying to rank order like what's the thing that's really going to cause them harm. The first thing I do is I acknowledge I understand why you use drugs. It totally makes sense to me. And if I were in your circumstance, I would be using drugs too. And I just think like making yourself a lot closer to who that patient is and their experience. I think about this one all the time. I think about the people that Becky's seeing who live and sleep under an overpass. I would use, I drink all day and I'd use Coke all night. That's how I think I would manage for that. And I sort of sit in that space with them. And yet we can acknowledge the harm that sometimes that causes them. There's a lot of chronic disease management we do that's actually, quite honestly, ready for this. It's not that important. Like chasing somebody's A1C down to a super low number, is it really going to change their health outcomes in 5 years or 10 years? Not necessarily. And I live in a world where primary care has been tasked the job of chasing numbers. It's not a great part of our job, right? Whether it's a checkoff box of did you do all the preventive care things, when although we all believe in prevention, I think we can all acknowledge that, how many mammograms does it take to detect one real case of breast cancer? It's a big number. And yet the number needed to treat when it comes to opiate use disorder or alcohol use disorder is a much smaller number. And I wish that all of us in primary care could get off the track of chasing the checkoff boxes and chasing the numbers and be like, wow, the thing that's really going to improve your overall health is for me to fill out your disability form today and get you some cash so we can get you housing. That is the thing that's going to change your health outcome for the rest of your life. And having more help and support in that work. I love filling out paperwork because I actually think to myself, better I fill out paperwork and get a patient really what they need, whether it's a comfort animal, get their license back, than writing them another script for a drug that doesn't work that well.
Thanks. Anyone want to respond? Anything that's been said before we move on? No. Okay. The next question is about innovation, and if you can share an innovation you've implemented, big or small, that meaningfully improved care for patients with substance use disorders.
I haven't started yet, so I'll
Yep.
take it for the team here.
Hey, I was going to call on you if no one volunteered, Christine.
I read your mind here.
Yep.
Um, well, so I think the two that came to mind for this, one was one that we implemented really recently. Um, I oversee staff at our Brockton Behavioral Health Center, which is an inpatient psych program and a clinical stabilization services program based in Brockton, affiliated with BMC. And the CSS is like a 14-day kind of post-detox level of care for individuals with substance use disorder. And we were able to start hepatitis C treatment at that program about a year ago. And that was so fun and so great to do. And I think it was really striking to me. I think, Hep C treatment has been, at least for the last 10 or 11 years, has been so much less burdensome and so much more effective for our patients, but has still really, there's I think a cohort of our highest risk patients who have just really struggled to get reliable access to treatment. And it's been quite remarkable how many patients come through this program with untreated Hep C and what the opportunity is. Where we start them on medication. We do sort of full service evaluation, start medications, and then we have a pharmacist based on BMC main campus who does telephonic follow-up with them through the completion of treatment and sustained virologic response. And we haven't had a single person who has fallen out of treatment or failed to get a sustained virologic response so far, and it's just been so fun. I think the actual single best part of that program, though, was the nurse practitioner who delivers most, if not all of the care, the majority of the care in that program. It's been mostly really cool to see his experience with gaining a new clinical skill and being able to like offer this new clinical service to our patients. I think just really gave a whole level of meaning to his work, and that's been a really cool part of it. And then I think through my pop health work at BMC, we have done a lot around complex care management, which is sort of multidisciplinary teams supporting individuals with very high levels of healthcare utilization. And in the sort of population health infrastructure, like a big goal there is to reduce total cost of care for our Medicaid ACO contracts. More than 60% of the individuals who are eligible for our program have a substance use disorder. It's like a huge driver of medical cost in Medicaid. And it has been, I think it can often feel really challenging to work on with this population from a care management perspective. You don't always have the same tools that you might in primary care because you're working with them with primarily nurses, with non-prescribers, et cetera. But it has been really neat and to sort of guide the journey of that program. And then we just got some match control data that showed that reduced overdose mortality in that cohort, and that was um, really exciting and really cool to see sort of the power of this non-physician-based team to really move the needle for this group.
Thank you.
I can go next.
Sure.
The thing that came to mind for me is not necessarily an innovation because there are a lot of other people doing this, but I think for a lot of people who aren't working in the field of addiction medicine, feels innovative or maybe surprising. So two things. Number one, I help my patients test their drugs. I'll be working with someone and they'll say, oh, like my current supply, I don't know what's going on with it. For some reason, the dope like they've been started selling it and it's purple. And I noticed I'm feeling a little bit different on it. And so we have a really great relationship with the Boston Public Health Department and Needle Exchange. And we have a medical van with a mass spectrometer on it. And so I will have patients who will say, I want to know what's in this. I want to know what I'm putting in my body. And so I'll take like a little baggie and I'll just take a little tiny piece of it and either myself or the recovery coach with me will bring that back to the mass spectrometer and we'll get an analysis to see, all right, like this is being sold as dope, but what is it actually? And what you find out is that it is a lot of things. There is like in methamphetamine, there's fentanyl, there's xylazine, there are benzodiazepines, there are other other things that like I've never even heard of. And I had a patient last week actually. He was homeless for a long time. He got housed a few months ago. And what's scary is that when my patients get housed, sure, they're under a roof, but they're no longer with their community and they're often isolated. And this patient, after using injection fentanyl for over a decade, he had the first overdose in like 5 years. And luckily, he did have someone with him, but it was very unusual for someone with such a high tolerance who's using all the time to overdose. And it turns out that he had changed the person that he was getting drugs from. And so for him, he's not ready to come into treatment. He's not interested in coming inpatient. He wants to continue using. And so I feel like my job as his doctor isn't to tell him, you need to stop using, you almost died, even though that's what I want to tell him because I really care about him and I don't want him to die. But the next step is harm reduction. How can I help him decrease the risk of dying or having a negative outcome from the things that he is doing? And so testing his drugs is one of those things. And then another thing is just bringing him the supplies to use in a safer way. And so I have this big backpack that I carry around with me. And in addition to all of my medical equipment and wound care supplies and ultrasound, I carry around a lot of drug use supplies, and I teach my patients how to use smarter. So, telling them to clean the skin before they use it, having a lot of needles so that they aren't reusing needles. Making sure they're not licking their needles before they inject, which unfortunately some people do that because they think it'll go in easier. And encouraging people, like if you can, don't inject at all, but maybe use nasally or use in some other way that will decrease the risk of an overdose. So those are some of the clinical tools that I use as a primary care doctor that I think probably not every primary care doctor is doing. Although, like Ruth said, these interventions, it's like a very low number needed to treat in order to make a really big difference. And the patients I'm working with, they feel that directly and it's part of relationship building by showing them that I'm not going to judge them for using drugs and I'm even going to help them do it in a way that is lowering their health risks, shows that I actually do care about them and I'm a safe person to come to when they're in crisis.
Awesome. Thanks, Becky. Ruth?
I feel like I'm talking to people on the panel, but also people in the audience who are students and learners who are training at a giant academic medical center. And and that's sort of the perspective you have. Like you have the sense of, well, I'll be working at a giant academic medical center myself, or I'll be teaching at one day. And for 8 years after I finished residency at Boston Medical Center, I stayed. And then one day a friend said, you went to medical school to be a rural family doctor. And I was like, yeah, I do remember that. And really the next day I had a job. And my job was where I grew up in Western Massachusetts, in a rural area in the second poorest county and the most rural county in Massachusetts. And what I realized pretty fast is something I already knew, which is you can have an outsized impact in a small area. That being a mid-size fish in a puddle has a really big impact. And I remember thinking, wow, when I was in Boston, I had a big patient panel. I went to work every day. I did a good job. But I never felt like I was making a big difference. And when I moved out to Greenfield and began working there, it was at the time this is a time prior to your listeners knowing this, but at the time there was you had a specific buprenorphine waiver, which allowed you to take care of 30 patients. And when I came out here, there was one other waiver in the county other than mine. And so we were allowed to take care of a total of 60 patients. And when I arrived, I was like, holy smokes, there's a big addiction problem here. It was 2010. And it was sort of when everybody was realizing we had a big problem. And I asked around, who's taking care of the people with addiction? The answer was, what addiction? I thought, oh my God. So it became really a shift for me. I was doing addiction always as just part of my normal practice because I think it should be a part of everybody's normal practice. Every one of you should be able to manage an outpatient alcohol withdrawal. The only requirement to prescribe buprenorphine doesn't matter what you are. You can be a cardiologist, a surgeon, doesn't matter. You just need a DEA license now. So if you're taking care of somebody with an opiate use disorder and that feels like the right medicine, please do this. But having an impact on a small community like this really changed the way I think about the outsized impact you can have. A few years later, the sheriff called me and said, I need a doctor at the jail. And I thought, okay, I'm pretty busy, but I'll cover for a little while. And now it's been 12 years. And I never thought of myself as providing correctional health care. It wasn't something that was a goal of mine. I think actually way too many people are incarcerated in this country. I was very worried about being part of the carceral system. And yet, an Eighth Amendment of the Constitution of the United States says that people who are incarcerated deserve the standard of medical care that you can get in the community. And I knew I could provide that, whether it was somebody who was male or female. I could do what Becky does and open any skin lesion and biopsy things and put in an IUD and manage a pregnant person. When I got there, I began taking care of my own patients. My office was a mile down the road from the county sheriff's office, and my own patients were getting incarcerated. So I was like, "Oh, this is perfect. Like it's inside the walls, outside the walls. They're all my people anyway." And I remember the day a guy of mine came in, a guy who's been stable on buprenorphine forever, a young kid, had gotten in trouble with alcohol. And he was off his buprenorphine because at the time the jail didn't do this. This was a long time ago. And he had lost his mind. He was yelling at me in the exam room, like, how could you take me off this medicine? You're the doctor here. On the outside, I get it. What are you doing? And I thought to myself, what am I doing here? And he said this, he said, you have created a missile. The day I walk out of this building, I'm going to use. And for those of you who don't know, people who leave jail at 120 times the rate of overdose death, that number is likely a lot higher than that now because of the supply being so much more toxic than it used to be. But I emailed the sheriff that night and said, something's got to change and we need to change it fast. And literally 12 hours later, we had a uh, facility wide meeting. And the decision that came out of that meeting was we need to start giving people buprenorphine. If they walk in here on bupe, we're going to give them bupe. This was one of the first places in the country to do that. And again, small jail, middle of nowhere, country doctor. And it was also clear to me that we needed to be providing methadone too. And when I applied for our methadone license, the federal government called me on my cell number, like within an hour of me submitting the federal application. And they said, we don't know who you are. We don't know what you're doing here, but it appears to us that you're getting a full methadone license for a county jail. And I said, yeah, that's what I'm doing. And they were like totally flabbergasted. And I said, is there something wrong? Because it feels to me like this is the place we should be providing this level of care. And at the end of the day, they were like, okay, we'll do it. It ended up being as hard as it was harder than honestly residency for me. It was harder than three natural childbirths. Getting my methadone license at a county jail was a giant pain in the neck. And yet, we've gone on. Every jail in Massachusetts now offers methadone. The majority of them are their own fully licensed methadone clinic. My little jail fills out their paperwork for them. And we have this little jail in Greenfield, Mass. Has been sort of a model of care around the country. We train the entire Federal Bureau of Prisons on how to do addiction care out of Greenfield, Mass. That's what it's like to be a small town doctor in a little puddle where you can make an outsized impact. So for those of you who think you're going to work in an academic center, I'm challenging you. I tell you, you can have a big impact in another part of the world.
Thank you. So we've touched a little on this, but in some of your answers so far, but to ask the specific question, what policies or structural changes would most improve access to addiction care right now?
I think that's an easy question that I just want to hear Ruth talk about, basically. But we need to get rid of the federal policy on methadone. It is completely bananas. I want to say a different word, but I'm not going to. That us as medical care providers and addiction experts are not able to prescribe methadone to our patients. So I'm going to let others talk about this.
Yeah, Becky took my answer right away, and it is bananas. I was saying the word bananas while you were saying it. So the rules on methadone were written in 1973, and they weren't altered at all until COVID-19 hit. And then all of a sudden things began to change. And there have been some changes that have made methadone less like liquid handcuffs in the clinic settings, but this is mainly the methadone industrial complex. There's a lot of money to be made in the 3,000 methadone clinics that are in our country. And there's a large rallying force against any regulatory changes. But there was never truly a good reason to remove the molecule of methadone from the rest of the pharmacopoeia. And yet it happened because it was 1973 during the war on drugs, during a time when the Nixon administration was having a war on people who use drugs. And we're well past the time where methadone needs to be released from OTP regulations and where anybody who has appropriate training to prescribe a medicine should be prescribing methadone for the management of both addiction and for chronic pain because it's a great chronic pain medicine. For those of you out there who will have your addiction, I'm sorry, your licenses to prescribe at some point, you can always use methadone for the management of pain, totally legal to do it. You should know how to do it because methadone is a funny molecule, but you can never use it for somebody who has opiate use disorder. And if they have opiate use disorder and chronic pain, you're really going to put yourself in your own harm's way and risk your license if you're prescribing for them. So it's a real limitation. But having said that, if you're working as a surgeon someday and you need good quality pain management, methadone is great. My hope with everybody, though, who goes into any field is that you know how to help your people who struggle with addiction. If you're a cardiologist and you're managing endocarditis and you don't know how to get somebody started on treatment, well, shame on you. You should know. Most hospitals do not have the addiction consult service that Christine works on at Boston Medical Center. They have a great one at Mass General Hospital as well, but the vast majority of hospitals do not have that. So you should call a friend and ask for help and figure out how to get somebody stable in treatment, whether you're a surgeon or a cardiologist or some other subspecialty, because you can fix their heart valve, you can repair their wound, but you haven't treated their underlying disease state, which is opiate use disorder.
Anyone want to add or build on what Ruth had to say? Christine?
No, well, I think I really agree with what you guys said. I think that an underlying, well, there's a lot of issues with the way methadone is set up, but I think one of the ways that most directly impacts our patients, besides just the structural barriers of actually getting to a methadone clinic every day, but there's like huge amounts of stigma that have attached to methadone as a result of that structure, and I think that's a really big barrier for our patients. And then I was going to say kind of more broadly, I think that, that stigma still continues to impact both stigma from medical providers, from communities, and from patients themselves. I think continues to really impact access to care and is just like something that I think we've made a lot of progress in the last decades, but there's still so far to go.
Yeah, great. Christine, you touched on like our next question, which is about stigma and structural inequities and how they show up in addiction care. And I'm wondering if there are other ways that stigma and structural inequities show up and how you all actively work against them in your practice.
Well, so I think for the type of stigma that I just talked about, I think as an individual provider, and I think this is really what a lot of us were saying about the sort of value of primary care, is I think we have a really unique opportunity to break down stigma that our patients may be holding around substance use disorder that helps, prevent them from getting treatment, as well as stigma that their families may have. So I always like really emphasize, this is a chronic condition, like it may have a sort of relapsing and remitting course. There's a real role for medication. That doesn't mean you're copping out on real recovery. If I was diagnosing you with diabetes, I wouldn't just say, hey, go run a marathon tomorrow and it will all be better. And I think there's sort of this expectation that somehow that's what we should do for addiction. And, I think I think the other reality is like for medicine overall is like it's treating addiction is unbelievably rewarding and often many times more rewarding than treating many other chronic conditions. And I think I really look forward to a time when healthcare providers really understand that. And I think it will really help pe more people start to treat and really engage on it. So I think
Yeah.
that's definitely where I would start.
Becky or Ruth, do you want to add or build on stigma and structural inequities?
Yeah, I think about this a lot. I'm 100% clinical. I spend all my time seeing patients, and um, my main clinic is actually at Mass General Hospital. I go outside and see patients, and then I also work in this little clinic where I can see people. And um, I think a lot of the judgment that people working in the traditional healthcare systems end up having about our patients comes from just like a lack of exposure and maybe some fear. And so whenever I have an individual case and I'm interfacing with healthcare providers in other specialties or in the hospital, I try to use each individual case as a learning opportunity. One example I can think of is I had this patient um, in her 30s, was living in a tent on the side of the highway, using injection fentanyl and really hadn't accessed medical care, had a lot of fear around going to the hospital. My team, we went to the encampment every week and would check in, give out socks, make sure they had access to water and food. And I started to get to know her. And then one day she said, I think I'm pregnant. And she never really got her periods because a lot of people who are actively using opiates, it messes up their hormonal cycles, and so they don't really know. And the way that she found out was that she thought she felt a baby moving, so she was pretty far along. And this patient, we ended up like trying really hard to get her to come into the hospital. We have a great relationship with the OB department there, but she just like did not feel comfortable. So I was managing her pregnancy outside. We got labs. She had a new diagnosis of HIV during this pregnancy, and finally, she came and was admitted to labor and delivery at the beginning of her third trimester. And she got on L&D, and having worked on L&D, I know that the culture often is not set up to take care of women who are using drugs. And I think like in part it makes intuitive sense because on labor and delivery, you have not just one patient, but two patients, right? Like you're taking care of the pregnant person, and then once there's a baby in the room, you're also looking out for the welfare of the baby. And there are a lot of feelings about who should parent and who shouldn't, whether or not they're right or wrong. And so when I went and met with my patient as she was on labor and delivery, getting started on methadone. The nurses approached me and said, "Oh, do you know her? Like, I think she has drugs in her room, and I think she might be using in the bathroom. And I don't know, like, I think we should get security to come and search her belongings, and you need to tell her that she needs to not do that. It's a safety concern." And and again, like this is like the stigmatizing stuff that comes from real fear from people who aren't used to encountering people using drugs. Um, and my initial reaction, and especially in residency, I remember thinking, oh my gosh, these people are being so judgmental. They're not treating this patient as a human being. This patient is really scared and vulnerable, and it's such a huge deal. I spent months trying to get her to come to the hospital to start methadone, and now that she's gotten here, she's kind of been treated terribly and isn't going to want to come back. But I ended up sitting down with the nurses and saying, like, thank you so much for your concern about this person. I've been so worried about her. She's been living in a tent and like without access to running water, and it is such a huge deal that she's here. And I know patients aren't supposed to use drugs in the hospital. That's absolutely true. But like what better place to use drugs than in a hospital where if you overdose, there's a whole team of people who can take care of you. And And then I told them about her backstory and about how she had been homeless as a child and abandoned by her mother, and her mother was using drugs, and that she had had to rely on sex work to survive and been abused by all these people, and that, like, this was someone who really needed their help. And yes, maybe she's not following all of the rules, but like, would you follow all the rules if these were your circumstances? And it turns out that that conversation led to a long conversation, and I've been pulled into the care of many patients who are pregnant as a result because they're like, oh, actually, like these women do need our help, instead of us like having a punitive approach. And I think stigma is a result of, local microcultures. And how do you change culture? That is such a hard thing, but I think the way you change it is person by person and telling stories and making people feel invested that they can be part of the care and part of the change. And so I don't have any like administrative roles. I'm not out there changing policy, but in like the little world that I work in, whenever I have a patient who's interfacing with other parts of the system, I try to teach as I go. And I think it's important because everyone listening to this, like maybe you're not going to be a street medicine doctor who takes care of people who are homeless. Maybe you're not going to be an addiction specialist. But the thing is that all these addictions are so prevalent, and it turns out that people using drugs still need cardiologists and endocrinologists and gynecologists, and they need specialists who are going to care and provide them non-judgmental care. And so um, that's how I think about changing stigma and structural inequities as like a day-to-day clinical person.
Thanks, Becky.
I'm not going to add anything to that. I think these two just did a great job.
Awesome. Well, then I'm going to share a question we have from our primary care track students, which is they are curious if the guests could speak more to how we could be doing better with addressing alcohol use disorder in primary care.
I'm going to start on that one only because I spent a lot of time both thinking about it and have been reworking some treatment protocols. But, first of all, we should presume that a lot of our patients are drinking. And, I think everybody knows demographically, the young generation, the 20s and 30s out there are drinking less than we've ever seen. The numbers are going down. And yet those who struggle with alcohol across the decades. And it's pretty harmful to people's lives. And so, yeah, screening people well about how much they drink and when they drink and the harm it could be causing them is important. 80% of alcohol is can be managed in the outpatient world. It's just that when you train, you're so skewed towards these inpatient alcohol withdrawals, phenobarb drips in the ICU, that in your head you think all people look like that. And I'm telling you, they don't. So for a long time, when I was working in full scope primary care and I was the addiction doctor within that system, people would send me their people with alcohol use disorder, and I would just do outpatient withdrawal management for them with either benzodiazepines or benzodiazepines plus a gabinoid. And it worked a lot of the time and it was very effective. And although we talk about medications for opiate use disorder, there are pretty effective medicines for alcohol use disorder that are profoundly underprescribed. And one of my jobs is I oversee some detoxes. And what we're finding is when we even look at the people who are coming through our detoxes, they really all, almost universally, could have managed with an outpatient withdrawal management. They just really are unhoused. They needed three hots and a cot. They needed a place to get away from the drug supply, the alcohol supply, and catch a break, catch their breath. So we just need more supportive housing that involves some medication management and some nurses on site, and we could do it a lot cheaper than we have been doing it. But I would argue every primary care doctor should be knowing how to manage alcohol use disorder much better than they are. When I asked the average primary care, they're like, is that my job? And I'm like, sadly, everything's your job when you're a primary care doctor. And I think that is a better use of your time than, quite honestly, about 100 other things that happen in a primary care office.
Any other thoughts on this question from our panelists? Yeah,
I
Christine.
think we can, I think we all know we can do a lot better in terms of identifying at-risk alcohol use among our patients. And I mean, that's really hard. As part of an early med director role I had at BMC, I rolled out alcohol use disorder screening and um, with one question. And, 16 years later, I can tell you it's very rare that our medical assistants ever administer that question. And, I've created all these like EMR tools to support PCPs with medication prescribing, and like 5 people a year use them. And it's just very depressing. But I do think that, that we have to continue work to figure out ways to sort of efficiently and effectively identify people who are like very early in having problematic use, because we know we can make a difference. And when I do have someone that I know is drinking a lot, and someone maybe they don't have a full-fledged or severe use disorder, but I'm concerned about development, I like bring it up, every visit, and just gently, low key, while I'm listening, like feeling their belly, or doing a diabetic foot exam or whatever it is, just to kind of remind them, like, I want to talk about this. It's a part of your health, and it has consequences. And I do kind of find that in general that um, young people are more health conscious now than they used to be, and they actually people respond a lot when I talk to them about the impact of alcohol use on things like blood pressure and cancer risk. And so it is I think there's a lot of promise there that we just haven't really figured out how to operationalize within all the demands that people have within primary care. Um,
Mhm.
The one other thing I'll add is that I think like in medical school and maybe in parts of residency, we were trained like you do the screener question, you figure out if they have an alcohol use disorder, and then if they do, you offer treatment and you offer ways to get sober. But I think we don't talk enough about the middle ground. Drinking in moderation, or someone who has been had like a heavy alcohol use disorder. Back in the day, they used to say, well, then you can't have even one drink. If you have one drink, then you're done. But in reality, I have patients who've had severe alcohol use disorder and they really haven't wanted to stop completely, and they have been able to moderate their drinking. And there's studies now showing that some of the medications that we use to treat use disorder with the goal of sobriety are actually pretty effective at just helping you cut down or using them as needed. I'm thinking about naltrexone and how sure you can say like you need to take it every single day or you need to get the injection and then that will be how you treat it. But you can actually just take it as needed. Like if you say, I'm going to be going to this party, I'm worried that things are going to get out of control because I know myself, you can just take it on that day. And it's been shown that that can be helpful in avoiding binge drinking. And instead of drinking like, I don't know, a 12 pack, you can just have a few. And my patients tell me that they feel that they take these medications and they just don't have the same interest. So
Mhm.
I would say as you go out and meet people who are struggling with their drinking, just remember that going down to zero is not always the answer for everyone.
Thanks. We have another audience question. They would love to hear your thoughts on the efficacy and impact of digital health tech companies in the addiction care space. Do you think telehealth models work? And how are physicians reacting to these types of opportunities in the health system for patients?
I am extremely far from an expert on digital health, and am like quite a cavewoman. In fact, however, I will say that one of the interesting things about in my population health role, we do sort of a combination of telephonic population health programs, and then some are much more intensive and in person. And um, one of the, I think, really important things to look out with any sort of remote supports is unforeseen consequences around equity. So we have,
Mhm.
and I've seen this play out in very different, unexpected ways. We have a team of social workers that do outreach to individuals in our Medicaid programs that are leaving psychiatric facilities, for example. And we really improved follow-up rates for people connecting with mental health care through this intervention. But the disparity between white and Black patients leaving inpatient psych and their ability to follow up grew. And conversely, within our buprenorphine program at BMC, we actually saw a narrowing in disparities when we introduced telemedicine capabilities during COVID. So I think it's maybe hard to predict what the impact of technology may be, but and by technology here, I mean the phone. But I think the similar lesson applies to digital stuff, is just making sure that we're really understanding impact on different populations that we're just hoping to support.
And I think anything that brings down the barrier to access to treatment is probably a good idea. And I think
Mhm.
one of the upsides to COVID is that it showed that to us. Um, I think that some of the data that's come out on some of these telehealth buprenorphine programs, particularly the ones that have peer support navigators or peer recovery coaches as the main support tool, they actually have really good retention rates at a much higher rate than even the average primary care doctor might have. And we're all sitting in Massachusetts right now, the highest uh, proportion of medical providers anywhere in the country, and people have very hard time accessing primary care in general in our state, in Boston. What if you're in Alaska? What if you're in North Dakota? And there's really a point where we really have to rely on every other way of reaching people. So I'm a big believer in whatever it takes. I've been doing work with the Alaska Department of Corrections, trying to get them to do treatment behind the walls. And that's a hard task. I'm not going to say it's easy. It's been challenging. And yet, the hardest part is they have nobody receiving. Once people leave the jail, where do they go? If you're outside of Anchorage, there's no treatment. And Alaska Medicaid rules make it impossible to do telehealth in that state. So it's a perfect state for telehealth.
Mhm.
People are flying thousands of miles, and it costs so much money to do these flights. And yet, telehealth isn't really allowed there. So people's access to treatment is really poor. So I'm a pretty big believer. You guys know that for buprenorphine, it would work. For oral medication for alcohol use disorder, it would work. For methadone, it solves for nothing, not in the current regulations. Having said that, the rules on methadone did change, so we can do telehealth intakes to a methadone clinic. That changed just in 2024. It's been a game changer for me, for us, because we're able to on a screen do an intake from somewhere else, which means we're able to do admissions 5 days a week. Anybody who walks in any door will see them.
Ruth, to quickly respond to that, I think in addition to sort of thinking about just actual access, especially in rural communities, I think the for people who are in communities or families where there's huge amounts of stigma, being able to get care through digital tools is like, I mean, literally life-saving. So as well. So I think it's really applicable even like on a crowded Boston street, like your ability to get care without being afraid that you're going to be seen. Um, and so there's just a lot more privacy.
Becky, anything to add? Or are you good?
Most of my patients don't have cell phone or internet, so this is
Hmm.
beyond my scope.
Okay. I just wanted to check. We have time for one more question, and I am going to ask the panelists to end on a note of hope about what is giving you hope right now in the field of addiction medicine.
I mean, I think the fact that we're even having this panel, when I was at HMS, I think I had a single 40-minute lecture on substance use disorder during 4 years. And so I think it's really great that, and then I remember maybe it was 10 years ago or something, I went to a section at HMS where Vivek Murthy, the Surgeon General, was demonstrating Narcan use on someone else. So over that time, that would never have happened when I was there. Let's just leave it at that. And so I think it's great that there's just a lot more kind of awareness of the centrality of healthcare and healthcare providers and physicians in particular really um, embracing substance use support and care. And so that's, I think, for me, like really exciting and overdue.
It's been a hard winter, and so it's taking me a moment to think about something
Mm,
to be hopeful about. Being in Boston, it feels like law enforcement is being used increasingly as the answer for a lot of problems that really just isn't appropriate. But similar to Christine, I do think that the stigma around substance use disorder in medicine has, I feel like, seen it changed pretty rapidly. Um, I, I'm 4 years out of residency, and so I haven't been an attending doctor for very long, and so even in like the time from medical school to residency and now as an attending, things have changed pretty quickly in the grand scheme of things, in the grand scheme of medicine. And so I'm hopeful, I'm having these conversations with people inside of the hospital with specialists, and they are interested in learning how to take care of people with addiction better. And so I think that's my point of hope right now.
Thanks, Becky.
Um, I actually feel a lot of the same ways that Becky and Christine feel. I love the fact that so many young people in training have a lot of interest in addiction, regardless of what they end up going into. They talk about it a lot. They want to get good at it. It matters. They know how important it is for their community.
Mhm.
I live in methadone land these days, and I believe that although I don't think a primary care doctor is going to prescribe methadone anytime soon, I actually think the liquid handcuffs on methadone clinics are starting to break hard. And that's because there are methadone clinics moving in that if you don't do your clinic treatment better, your patients are going to leave. I like to see competition in methadone. I want patients to get the best quality care. And if they need to go somewhere else to get it, then do so. Um, and quite honestly, the long acting, I know I'm being very specific here, but the long acting injectable medication with buprenorphine are super effective for people.
Yeah.
They don't have to get in their own heads about it. They can get off when they want to. I do think there has been some pharmaceutical technology that has arisen that's been excellent. Um, I am not a believer that the psychedelics are going to cure people from their addiction, but I do think for some people it could make a difference in the states where that's legal. We're looking at using high dose ketamine for sort of salvage therapy for alcohol use disorder. I think people are being pretty creative about trying to help people who really, really suffer. So there's a lot of really exciting things going on in the world of addiction these days.
I personally think that if Ruth got jails across the country to start providing methadone and buprenorphine, she'll be able to get primary care to start prescribing methadone pretty soon. So,
It hasn't been across the country that we've broken in everywhere, but we're going state by state for sure.
and it's made such a difference. I mean, it's amazing.
Huge difference in the state of Massachusetts for all of us who take care of patients in and out of jail to remember the old days where they would have to do a hard withdrawal and they would say, I didn't sleep for 54 days. And if I could have found a way to kill myself, I would have. And people
And I
did.
have
People,
patients who did, yeah. And
yeah,
I
they
mean,
did.
it's the single most like the single two most heartbreaking cases in my life were from that like complete human rights violation of not providing these meds in jail. So
Yep.
we are very grateful for your work in that.
Well, thank you all for your work and thank you for joining us this afternoon. We've been so fortunate to spend time learning from you. Thanks to all our attendees. Our next session is going to be exploring non-traditional career paths in primary care, and we'll be reaching out soon with a confirmed date and lineup of speakers. Thanks again to our guests and panelists, and have a great rest of your day.